Thank you very much for the invitation and thanks for attending this lecture. In the last 10 to 15 years, I think a lot of you have encountered a term called deep gluteal syndrome or DGS. And it's a term that have been used quite commonly to replace or interchangeably with the piriformis syndrome. I'm going to just summarize some of the reasons why there's a change and what are the new concepts when we encounter patient with a deep gluteal syndrome. Is there any particular type of treatment we should do? This is my disclosure slides, and most of the pictures are coming from these three books. So let's just pause for a moment. When someone show in a clinic, and what do you think when someone have a pain in the buttock or gluteal region? Now, I'm not talking about your annoying colleague, but I'm talking about a patient who have this with some sort of a symptoms that's suggestive of a sciatic nerve irritation. And the first thing you probably would say, can it be just a piriformis syndrome? Well, this is a fairly commonly used diagnosis after you exclude the cause from the spine. And last time I checked, there probably are 25 of those review articles published on piriformis syndrome. It refers to the pain in within the gluteal region associated with sciatic nerve irritation, and you exclude the spine cause, and you do some fancy tests like PACE test, BT test, FAIR test, and fiber test. And when you perform those tests and it's positive, and then you think, the patient may have a piriformis syndrome. And one of the reasons why people say this because, well, first of all, piriformis is the largest muscle and it's only muscle that transfers through the glycosciatic notch. And because of the geographic location, the important nerve that go from the pelvis to the lower limb will go above or below, and it's then covered by the real biggest muscle in the body, the one called gluteus maximus, and encodes in a space there. And the second piece of fact I want to just show you is we all know sciatic nerve have known variations with the piriformis muscle, and this article summarized the last 100 years of those report that summarize the variations. And because the sciatic nerve can go above, below, or even in between the piriformis muscle, we believe that when there's some abnormal contraction of the site of the piriformis, it may cause some sciatic nerve irritation. And because of this, we have a term called piriformis syndrome to describe the pain in the buttock with a sciatic nerve irritation. But let's just pause for another moment and think about this. It doesn't sound right. It does not sound right. It does not. So, first of all, it's not uncommon for someone who have a piriformis syndrome to have some investigation. And one of the investigation is MRI of the nerve, the MR neurography. And I would say most of the time when I have those scans done on those patients referred to me, they are normal. They don't have an abnormal variation of the sciatic nerve. The second thing you probably know if you look at the diagram, the sciatic nerve have a close relationship to the piriformis, but also it lie on many short rotator muscles. There are 6 of them altogether. So why do we have to pinpoint one muscle of the 6 and call it a piriformis syndrome? This is the diagram similar to the one I illustrated. The sciatic nerve can usually just exit inferior to the piriformis, but also have an intimate relationship with a number of rotator muscles here. And then there is also a number of nerve around, and it's covered by the gluteus maximus muscle and into a very enclosed space that we call deep gluteal space. A lot of things can be wrong in this area. So what is deep gluteal syndrome? It is the presence of pain in the buttock caused by non-discogenic or extrapelvic entrapment of the sciatic nerve. It embraces a much wider spectrum of anatomical structures and etiology of a sciatic nerve involvement. Now, this was termed in 1999, so it's not something too new. But if you're interested in this, this is one of the very nice review articles summarized about a lot of things that you should know about DGS. I wanted to touch base on a lot of new concepts and what contribute to the new concept or the evolution of the Gluteal syndrome. There are 4 different aspects. The first aspect is the imaging. There's a different type of new imaging that helps us to understand more about the gluteal space. One is we call dynamic ultrasound. Again, this is a cadaver specimen of the deep gluteal space. You can see the deep to the gluteus maximus. When you remove that muscle, you can see the sciatic nerve lie between the piriformis and a number of the short rotator. If you apply a long axis scan of the sciatic nerve, again, it's a schematic diagram of this, and you can see left-hand side is a cephalad, right-hand side is caudal, the sciatic nerve sagittal scan, and deep to this is the superior and inferior Gemini muscle. The tendon here is from the obturator internus, and you can see a larger muscle, which is quadratus femoris. So the sciatic nerve is in a smooth contour. But when you start to internal rotate the hip, the sciatic nerve will not assume a smooth contour. And as a matter of fact, you can see here, it looks like it's being buckled. So it's superior inferior Gemini, obturator internus, and quadratus femoris. Now, what does it mean? It doesn't mean you will have symptoms right away. But what it does is it decreases the excursion movement of the sciatic nerve. Now, what does it mean? So I will keep on talking about this, but I will get back to the deep meaning of decrease of the excursion movement of the sciatic nerve. The second one is the MRI, the high resolution, or the MR neurography. So here we can see a axial scan. We can see the piriformis muscle here look like a little bit bigger. When you do a coronal scan, you can see the piriformis muscle. Sciatic nerve is around here, but you don't get those details. So there is something called the MRI, and you can see much higher detail about sciatic nerve. You see something here, not right. There's something transverse through the sciatic nerve. We don't know what is this, but I can tell you this is a fibrous band that actually is adhere to the sciatic nerve, and it can be the cause for the etiology of the sciatic nerve irritation. And then when you have a better resolution, you can have an even better understanding of the nerve signal praxis with the MRI called MRN. The third is a tractography. It's a special kind of MRI with a diffusion tension scan, and tend to recruit with a technique those neural pathway of a similar function together. So that's why we call tractography. It has been used for the brain, but my friend and colleague called Dr. Limos from Brazil, he has already started to work on the possibility of outlining the track of a similar function in the pelvis, and it's called the tractography in the pelvis. And from there, I think you can understand the relationship of the nerve with the tissue around, like the variation of the S2 here as well. All right, the second corner that changed the concept of a DGS is the surgical specialty or surgical technique. One is we call periarticular hip endoscopy. So we are not talking about endoscopy of the hip like a hip arthroscopy. We are talking about the endoscopy of the extra-articular portion. So if you are interested, there is actually a very good review article dating back to 2012. So what does it mean? Between the gluteus maximus and the short rotator muscle of the hip, the space you can actually insufflate it, and then you can see well inside. And this is one of the setup. You can see the hip there, and put a scope deep to the gluteus muscle. And what does it mean to you? Well, we can see the sciatic nerve in a much better sense, not just in the MRI, which we construct and guess. We can see it directly. So from there, actually, it enhances our knowledge that the sciatic nerve can have some fibrous band, and one that we call the compressive fibrous band actually tend to choke and decrease the movement of the sciatic nerve. The other is called adhesive. It actually is stuck on the surface and prevent again the excursion movement of the sciatic nerve. I will explain what does it mean in a moment about decrease the excursion movement of the sciatic nerve. You can have a miscellaneous one that actually circumferential and choke on the sciatic nerve, decrease the circulation and causing entrapment as well. So the advance of this endoscopy technique is not just to confirm to see what we guess from the MRI, say here's a sciatic nerve, there's a fiber span. The sciatic nerve, you can see the fiber span. But most important is the surgeon can actually operate and remove the fiber span. So not just in a diagnostic sense, but also in therapeutic sense. All right, so the next thing about the surgical advance is called pelvic So it's a group of the gynecologists. They function almost like a neurosurgeon inside the pelvis. One of my colleagues called Zelio Limos, he's a gynecologist from Brazil working with us. We published a kind of a comprehensive experience over the last 10 years about the laparoscopic approach to those extra spinal sciatica and pudendal pain from the intrapelvic nerve. So the orthopedic surgeon worked in the extra-articular space from behind deep to the gluteus maximus. And this group of gynecologists, they work from inside deep to the piriformis and rotator hip muscle. Why is important? Well, think about this. So there's a lot of entrapment in the sciatic nerve, which contribute from L4-5 and S1-2 and 3, and can be entrapped inside the pelvis, like within the piriformis muscle. It can be. So I just give you some example. It's very hard to orientate, but basically you're looking inside. This is the caudal. Your scope here is a cephalic and caudal. Here is a S2 nerve, S3 and piriformis muscle here. The S3 have been free from the piriformis muscle. So you can see a piriformis muscle here, and in between there's no piriformis because it was clear because the S3 was entrapped inside the piriformis muscle, So, and this actually is that you work from within, and now after you cut free the piriformis muscle, you can see the S3. And this is another one. So they find it's not just the muscle entrap a fiber span. The vessel itself can cause what we call nutcracker syndrome. And here's the one that the S3 again is involved and was looped by this vessel. But by cutting this vessel, you can now see the S3 is now free. So again, there's a new type of understanding about the deep gluteal space. All right, the third corner of the understanding of a deep gluteal syndrome is about the sciatic nerve physiology. One is the dynamic stretching. All right, we know that sciatic nerve is the longest nerve in the body. And when we have some movement like extreme flexion, squatting, we stretch the nerve. And the computer simulating and also in the animal model, we know that 28 millimeter excursion is fairly normal when you do the hip flexion, but it's probably around 3% of the pulling or stretching of a nerve. But when you stretch a nerve by 6%, you can cause some numbness, which can cause a string-related neuropraxia. And when you stretch a nerve by 12%, that's more than 10%, then you can actually have a complete nerve block without blocking the nerve. So how do you achieve those? So I just want to show you. So when you actually do we call strict raising, and that's the reason why we have that irritation, because you really stretch an irritated nerve and augment those pain from the irritation. So usually by 80 degree, you are achieving close to 6%. But usually we don't keep in this position for a long time. Well, sometimes we do. Well, think about this when you do when you do yoga, we call what's that called? The frog pose. You can do this for some time, and you again stretch your nerve. And you can say, well, I don't do yoga, but then in many countries, the bathroom, the toilet is not sitting toilet, it's a squatting toilet, it's a hole on the floor. So if you have some bowel issue like severe diarrhea or constipation, you may squat in that extreme frog pose for some time, and then you can get numbness and you may not be able to get up at all. So this is something that happened. Think about this. When you stretch your nerve, and under normal circumstances, you won't actually go to the extreme. But if you have some issue, like you have a scarring of fibrous band in your sciatic nerve, like what I described before. So part of the nerve, sciatic nerve are not mobile. So when you stretch basically the rest of the mobile sciatic nerve, and then the mobile segment of the sciatic nerve will have a strength by more than 3% as you think, because it's a smaller portion of the nerve that is fully mobile, and you can easily go to 6%. So that's the reason why I keep on saying when you have a decreased excursion movement of the nerve is not a good thing. The second is about the understanding of the functional position. Well, what does it mean? For those who actually do running, you know that when you do jogging, running, your hip are rotating all the time. That's why we have 6 rotator muscles, just keep rotating the hip and rotate all the time. And what does it mean to the sciatic nerve? What it means is, this is the gluteal, this is isquiotuberosity. When you walk and when you run, the sciatic nerve will get closer to the gluteal, and then in a certain part of the running, and it bounce back towards the isquiotuberosity. So the nerve will move medial naturally. I remember some years ago, I was in Hong Kong, and there is a pre-meeting when all the faculty are being given some challenging patients so that we can try to help them to solve. One of them is a sportsman who do a lot of running. So he have no symptoms at rest, but when he start to run, he feel like a sharp stabbing pain down in the sciatic nerve. So everyone tried to examine him, and we investigate and show the previous investigation about the sciatic nerve in the spine. Everything was normal. Well, and including the MRI of the sciatic nerve and the spine. But when we do a dynamic scan, we find that actually when we try to flex his hip and extend the hip, first thing we saw something very strange. He have a known history of tear of the hamstring, which is here, and then he ignored this, and he have a calcified tendonitis, and the calcium is so big and sharp is like a razor blade. So when he walk, the sciatic nerve keep bouncing and hitting the sharp calcium. So that's why he have literally a sharp shooting pain down the sciatic nerve for a reason. And once we know that we diagnose this, the treatment will be easy, because we can just decalcify and break down the calcium, and the patient will feel much better afterward. All right, the last thing I want to show you is how we contribute to the current understanding of DGS is not just the physiology, but also the anatomy. Well, you say, anatomy should be the same. Well, yes, but then we understand better. I'll give you an example. The cause of sciatic nerve. We always say the 6 variation, and then people fixate and obsess with this. But it's not just the variation of the sciatic nerve with respect to the piriformis. I'll give you some example. Here is the piriformis and the other short rotator can have a common insertion site, and in that case, it limits a lot of excursion movement of the piriformis, way more than the variation of the sciatic nerve within the piriformis. And here is another extreme. Even the gluteus muscle attachment are basically have a common origin with all the other rotator muscle of the hip. And in that case, the whole sciatic nerve basically are just quite stuck and very limited in the excursion movement. Okay, the nerve muscle interface. Now, I think this is the anatomy. So the first time people appreciate was due to a Japanese radiology study. But you notice inside the piriformis is not just a sciatic nerve. The sacral plexus is there. The sacral nerve root is there. And they find quite commonly the S3 and sometimes S2 are inside the muscle. And so that's the reason why we start to do some dissection and find that around 40%, 30 to 40% of the S3 are entrapped inside piriformis. They may not have a symptom, but if someone have a symptoms, someone have a MRI of with a swelling, and then we have done a diagnostic block in S3, and they have relief, then we can make a diagnosis. And what does it mean? It means actually the surgeon can go inside with a laparoscopic approach and remove the piriformis muscle, which basically you don't really need it because you have other muscle to help you for rotation, and then free the sciatic nerve. So this is something that we rarely talk about, as we call the nerve muscle interface. So I summarize the 4 different aspects that change the way how we understand the gluteal space, and we can just by understanding this, we know that piriformis syndrome is a way oversimplified version of description of the type of pain entity in those patients.